Chapter 14, we're going to talk about alterations in hemostasis and blood coagulation. Hemostasis is the arrest of bleeding or prevention of loss of blood from an injured blood vessel. It involves the vessel wall, platelets, and plasma coagulation proteins, many of which come from the liver. Now, hemostasis, if it's inadequate, can lead to bleeding disorders, and hemostasis, if it's excessive, can lead to clotting disorders or thrombosis. Now, there are several main stages of hemostasis, and we'll first start here with the primary hemostasis. It's initial response to vascular injury that involves the interaction of platelets and the endothelium or exposed underlying extracellular matrix to platelets. Now, this injured vessel will vasoconstrict, and this prevents blood loss. And it also leads to the formation of a platelet plug because once those platelets can sense there's exposed tissue in this vessel, they'll start to initiate their platelet plug formation, which is where they start to stick together. Now, secondary hemostasis involves the formation of a fibrin clot or mesh through both the intrinsic and extrinsic coagulation pathways. And the final stage of the secondary hemostasis is clot retraction, where platelets will start to retract due to their actin filaments inside the cells, and this starts to pull on the clot and bring the edges of the torn tissue closer together, which improves healing time. So what does this look like? Now, if we look at the primary stage of hemostasis, what we see then is that platelets become activated when they're exposed to the collagen or extracellular matrix in a damaged blood vessel wall. Once these platelets are activated, they'll start to release different factors like adenosine diphosphate or thromboxane A2. And what these can do then is recruit more platelets to the site of injury, and this is going to start the beginning of the platelet adhesion or coagulation. Now, part of this pathway is the conversion of fibrinogen into fibrin, which is the secondary phase of hemostasis. Now, the secondary phase of hemostasis occurs with both the intrinsic and extrinsic pathways. The intrinsic pathway is a series of biochemical reactions we can see here that are activated in response to tissue activation factors. What we find then is that these clotting factors become activated in a series of sequential events that all lead to the production of an enzyme called thrombin. Now, thrombin is an enzyme that can convert fibrinogen into fibrin, and fibrin is the precursor to the fibrin mesh, which we can see here. Now, what we find then, too, is that the extrinsic pathway is an additional aspect of this clotting cascade where other tissue factors can activate different biochemical mechanisms that leads to also the production of a fibrin mesh. Now, fibrinolysis involves the breakdown of the fibrin mesh while the wound is healing. You don't need this fibrin mesh in the injured tissue or vessel wall forever. So what happens is that eventually, with the breakdown of the blood clot, we have these plasminogen activators that convert a precursor enzyme plasminogen into an enzyme called plasmin. Plasmin is a fibrin digesting enzyme. And what plasmin does is it goes into the fibrin mesh in the blood clot and starts to eat the fibrin mesh through a process we call fibrinolysis, or breakdown of the fibrin mesh. So what you get is the degradation of that fibrin mesh in the clot, and basically you can break down that blood clot. Now, in terms of the evaluation of hemostasis and coagulation, different clinical assessments can be performed or noticed. Pallor is common. Jaundice, hemarthrosis, which is blood in joints. You can see this with bleeding disorders. Telangiectasis or ataxia, which is a form of hematoma. Otherwise, you can see things like petechia, purpura, and ecchymoses, which are also forms of hematomas that we'll talk about soon. So petechia are small, sort of pinpoint types of hematomas, and what these are basically just little microhematomas you can find in some of the capillaries and smaller blood vessels throughout the body. Now, you'll see petechia in bleeding disorders, because if someone can't form blood clots adequately, then they're going to get small hematomas every time a blood vessel is ruptured. And this can be clinically assessed through the appearance of these petechia, or basically pinpoint hematomas. Purpura is also possible as well with bleeding disorders, because what we can see here that there are larger hematomas that spread through larger patches of skin, and this is also common in certain bleeding disorders. Telangiectasia is also a common form of bleeding disorder. It's heritable, but it often shows up on the skin of the face. You can see it almost looks like a petechia on the face. Vascular and platelet disorders, the primary cause of bleeding is a problem with the vascular component of the wall. So what we find here then is that some vascular disorders where the blood vessels may be damaged or malformed and weakened, that can cause an excessive amount of bleeding. Now this can be acquired or inherited, and so some different types of vascular and platelet disorders we're going to talk about in the following slides. And we'll talk about here the hemorrhagic telangiectasia. It's actually an autosomal dominant trait, so you find family history in both males and females. What you find here then are dilated, tortuous, small blood vessels that easily bleed, and the vessel wall is actually just made of a single layer of epithelium. But in this particular heritable disorder, the vessel wall is particularly weakened, which then makes it more likely for these individuals to have ruptured blood vessels or hematomas. Now, other platelet disorders can be a primary cause of bleeding, and now this is usually due to a deficit in the quantity or quality of those platelets, and again, this can be acquired or inherited. So one example of a platelet disorder is thrombocytopenia, and a common cause of this is either bone marrow suppression from chemotherapy, any recent immunization, or excessive alcohol ingestion, which can lead to low platelet count. Now, this low platelet count can lead to prolonged bleeding time, petechia and purpura, and treatment for thrombocytopenia is really just based on identifying the root cause. If someone has bone marrow suppression from chemotherapy, well, then you should expect them when they're off their chemotherapy, their thrombocytopenia should reverse. Or if they have bone marrow suppression from too much alcohol ingestion, which could lead to thrombocytopenia, treating that alcoholism or addiction should be one of the treatment methods there. Now, thrombocytosis is the opposite, where you have a platelet count greater than 400,000 per milliliter. And what we find here that it can be transitory due to stress or physical exercise, but the primary cause of thrombocytosis is polycythemia vera or chronic granulocytic leukemia, where you can get an excessive amount of platelets due to basically a neoplasia of bone marrow. A secondary cause of thrombocytosis could be a response to hemorrhagic processes or other disease processes, even splenectomy, because if someone has their spleen removed, then they can't remove excess or store excess amount of platelets as well. Now, these qualitative platelet disorders include basically a series of inherited disorders like Bernard-Soulier or von Willebrand disease. And this is the ability of platelets to function in the normal hemostatic process, but that process is abnormal. So what we find then is that platelets lack the ability to properly adhere, aggregate, or release their clotting factors in a normal way. And because this is abnormal, then we find that there are bleeding disorders that result from an abnormality in the function of platelets. Now, we'll next move on to talk about the coagulation disorders, and this includes coagulopathies, which are basically defects in the normal clotting mechanism. Now, the problems that can result from a coagulopathy can be due to bleeding from a formation of lack of formation of clot, and this bleeding can become a problem if the clot doesn't stabilize properly. Now, you can also get excessive clot formation due to inappropriate activation of the coagulation cascade. Now, the first type of coagulation disorder we're talking about are the hemophilias, and hemophilia is the most common inherited coagulation disorder that results in excessive bleeding, especially in joints. Think about the joints of your body and how much stress they encounter over the course of a day. Well, you should expect then that just by using a joint, you could damage several blood vessels in that joint. Now, if you had a coagulation disorder like hemophilia and you couldn't repair those damaged vessels, that means that even just normal amounts of activity could lead to excessive bleeding in joints, which we call hemarthrosis. Now, there are different types of hemophilia. Hemophilia A is due to a deficiency of factor 8. Hemophilia B is due to a deficiency in factor 9. But with both of these, what we find then is that the extrinsic and intrinsic pathways are affected, and therefore they can't form a proper fibrin mesh to get a nice blood clot to stop excessive bleeding. Now, von Willebrand disease is an autosomal dominant disorder of factor 8. And what we find then is also platelet dysfunction that is associated with this. This can lead to excessive bleeding, so we'll see prolonged bleeding time, but we do see a normal platelet count with von Willebrand disease. Vitamin K deficiency can also lead to coagulation disorders. So we know that vitamin K is a fat-soluble vitamin, so it's normally stored in excess in your body. But if you have vitamin K deficiency, this can be due to malnutrition, malabsorption, or chronic hepatic disease. And because vitamin K is an important aspect of the clotting cascade, lack of vitamin K will result in excessive bleeding. So it's important for individuals to have enough vitamin K in their diet over the course of a long period of time. That way they can actually form a normal blood clot. Now, disseminated intravascular coagulation, or DIC, is an acquired hemorrhagic syndrome where clotting and bleeding occur simultaneously. And that sounds kind of weird, but the cause of this can include trauma, malignancy, burns, and shock. And the reason why you get both clotting and bleeding simultaneously is that widespread clot formation in small vessels can actually lead to the depletion of clotting factors. So once your clotting factors and platelets have been consumed, and there's no additional clotting factors or platelets in your bloodstream to form new blood clots, this results in excessive amounts of bleeding. So you see DIC, or disseminated intravascular coagulation, as a consequence of trauma. Let's say if someone has a really large wound, their body will try to block all of those hemorrhages as much as it can, but eventually you're going to run out of clotting factors and platelets because those exist in your bloodstream as a finite resource. And if that happens, then you could get some clots that form, but you're going to see clotting and bleeding simultaneously. And this is due to basically exhaustion or elimination of those clotting elements. This is actually going to be treatable with basically serum transfers of clotting factors and platelets. It turns out that hepatic disease can also result in coagulopathies. And because the liver is involved with absorption of vitamin K, if the liver's failing, then you're going to have vitamin K deficiency in that regard. The liver is also necessary in the synthesis of clotting factors like fibrinogen, as well as factors 5 and 11. And so if the liver's failing, then you're going to see a decrease in the synthesis of these factors, and therefore bleeding disorders can result from hepatic disease as well, or the inability to remove activated coagulation factors, other proteins from circulation, as well as altered production of inhibitors of coagulation. So you can see odd bleeding disorders that can result from hepatic disease.